Even lower still, it's not white because the dye hasn't reached this area yet, but from leak from plain peritoneal dialysis fluid, you can see the heterogeneity of the signal here because of dialysis fluid that is caught in the abdominal pannus. This is a man who presented with a swollen testicle, and again, radiocontrast dye was instilled with PD fluid, and you can see the white color that is in both processus vaginalis. Therefore, this patient has bilateral processus vaginalis, but you can see in the lower cut that there is really a marked gathering of PD fluid within the scrotal sac, like a hydrocele, but composed of peritoneal dialysis fluid, and that was the cause of the scrotal swelling. This kind of thing is easily repaired with surgery, closing up the patent processus vaginalis. So here is a diagram that shows the two pathways by which the peritoneal fluid can reach the genitalia. The first is the patent processus vaginalis. Now, normally this closes up in fetal life, but in a sizable percent of the population, males more than females, it may remain patent into adult life. And if this provides a communication between the peritoneal cavity and the scrotal or labial sac. So if the patient puts in fluid in the peritoneal cavity under raised intra-abdominal pressure, it will flow through this patent processus vaginalis and present with swelling of the scrotum, or less commonly, the labia. The second way the dialysis fluid can reach the genitalia is like the patient I showed you with the open laparoscopic porthole, and there is some break in the peritoneal cavity. It could be where the catheter was inserted, the porthole, a hernia, some sort of tear in the peritoneal cavity, and the fluid leaks out into the tissues, the soft tissues like I showed you before, and it just works its way by gravity to cover and give penile edema, edema of the scrotal wall, or less commonly, edema of the mons pubis. What do we do when patients present with this complication? It is pressure driven, so sometimes the patient can be managed, at least temporarily, by doing peritoneal dialysis under conditions of lower intra-abdominal pressure. And that means getting rid of a day dwell in a night cycler peritoneal dialysis patient, so they're dry during the day, and doing night cycler with the lowest volumes that you can get away with in terms of adequacy of dialysis considerations. Or you may elect to change the patient to temporary hemodialysis to allow healing if it's a tear or something like that. If it's a leak in the abdominal wall, it's important to do a CT scan to look for an occult hernia. Sometimes, especially in obese patients, these may not be all that obvious on clinical exam. If it's genital edema, do a CT scan or a radionuclide scan looking for patent processus vaginalis, pictures of which I showed you before. And as mentioned before, these are usually quite easily surgically repaired. So our man with a swollen penis due to the open laparoscopic porthole was reverted once again to night cycler dialysis, dry during the day, and the edema got better. We kept him on low volume day dwells and then were gradually introduced over time. There was no recurrence of the leak, which meant that the porthole probably finally healed up completely, and he did very well on peritoneal dialysis, continuing on this therapy until he successfully received a second kidney transplant. This is a very different problem of a woman who decided to do peritoneal dialysis, had an uneventful insertion of a PD catheter, came for training, and was discharged on the APD regimen that you see here. Just a few days later, she called the unit complaining of progressive shortness of breath. This is very unusual for an elective start peritoneal dialysis patient and should conjure up a certain diagnosis. It would be unusual for a patient to get shortness of breath just due to fluid overload in this kind of scenario so quickly after starting peritoneal dialysis. Here is her chest x-ray, and you can see that there is a large right-sided pleural effusion. What this patient has is hydrothorax, or fluid in the right pleural space, as a result of leak of dialysis fluid across defects in the right hemidiaphragm from the peritoneal to the pleural cavity. And this is driven by a pressure gradient in the face of these defects somewhere in the hemidiaphragm. Usually the diagnosis is pretty obvious if a patient very soon after starting on peritoneal dialysis complains of shortness of breath and has a large right pleural effusion. However, you can also make this diagnosis by thoracentesis, which would also be important to treat the patient's shortness of breath, and the fluid that is withdrawn can be analyzed. It should, of course, be a transudate because it's comprised of PD fluid. It may or may not have a high glucose concentration reflecting the composition of the peritoneal dialysis fluid itself, and the cell count should be variable, but again, should not be overtly bloody or pussy. Some people like the idea of giving intraperitoneal methylene blue and then doing the thoracentesis and looking for a blue color in the withdrawn pleural fluid to prove the migration of fluid across the hemidiaphragm. It's not a good idea because methylene blue is a chemical irritant and can be very painful to the patient. And furthermore, the methylene blue may be so over diluted in the PD fluid that when the thoracentesis is done, the fluid may not look overtly blue, even though there is a communication between the two cavities. With this long dwell, why is the pleural fluid not really high in glucose concentration, reflecting the composition in peritoneal dialysis? Probably glucose diffuses out of the pleural cavity in a PD hydrothorax over time, just like it does out of the peritoneal cavity, and that is why the glucose concentration is not necessarily very high, because the glucose may have been lost. Also, the patient may be using a non-glucose containing dialysis fluid, such as icodextrin, in which case the glucose concentration in the pleural fluid wouldn't necessarily be high. So while we say that a very high glucose concentration in the pleural fluid is strongly suggestive of PD fluid hydrothorax, a glucose concentration that is no different from blood glucose concentration doesn't rule out the possibility that it is still PD fluid hydrothorax. Thoracentesis, as mentioned, may be very helpful if the patient is very short of breath. PD should probably be stopped. If the patient does need dialysis, then probably temporary hemodialysis is the best option. I have a talk with the patient usually at this time and say, if you want to remain on hemodialysis, there's nothing more that has to be done about this communication between the peritoneal and pleural cavity. However, if the patient wants to persevere with peritoneal dialysis, then something has to be done to get rid of this communication between the two cavities. And that is usually done by a pleurodesis with any of the sclerosing agents you see here, or by a direct operative or pleuroscopic repair under video-assisted thoracoscopy. After the pleurodesis or repair, we usually allow a healing time of somewhere between 4 and 6 weeks, and then re-challenge the patient with peritoneal dialysis, keeping a close eye on the patient to make sure that they don't reaccumulate the PD hydrothorax. The third case is of a building superintendent that